Okay, so some of you I've met before, most of you I haven't met yet. So I'm going to introduce myself, and we'll talk about what the expectations are for the course, and then we'll get into the opening block of nephrology, which is what we're going to start with. So I'm Lieutenant Colonel Grant Evans. I'm a urologist by training. Don't let that alarm you. I don't expect to turn any of you into urologists, and I definitely don't expect to turn you into nephrologists, because I'm not one. So you'll find that the nephrology section will probably be a lot lighter than the urology section, because I'm going to nerd out where I have the strongest background. That said, I'm going to tell you a little bit about my background, because just saying I'm a urologist by training doesn't really sort of paint the complete picture, and I want to give you guys an idea of what kind of experience I've had that led me to where I am today. Because I may be in a position to answer questions for you that you wouldn't otherwise expect to be able to pose to me. So I enlisted when I was 17, right out of high school. I was a field artillery forward observer for almost 6 years. For any of you who don't know what a forward observer is, that's the guy you see in the movies with the radio on his back and a handset going, "I need fire at such and such location," and stuff starts to explode. That's what I did. I didn't do a whole lot of calling for fire. So when I joined the Army, the War on Terror hadn't started yet, to date myself a little bit. It was 2 years before the Twin Towers went down. And then once the war started, there wasn't that much demand for field artillery forward observers compared to previous conflicts. And so field artillerymen ended up doing weird things that weren't necessarily in their wheelhouse. So I ended up getting deployed on contingency orders to Fort Polk, Louisiana. What did I do while I was at Fort Polk, Louisiana? Well, I started out guarding gates, checking IDs, and then after doing that for a couple of weeks, I ended up, as the resident security in COIC for the commanding general, because he had a protective services detachment. Why the commanding general at Fort Polk, Louisiana had a protective services detachment is a story for another time. Suffice it to say, he didn't ask for it, he didn't want it, but he was told by somebody with more stars than him that he was going to have one, and so there I was. So I worked as part of an MP battalion for the better part of a year, guarding a general officer's house. And while I was at Fort Polk, I got accepted to medical school at Oklahoma State University. I actually got my letter of acceptance after I'd only been at Fort Polk for about a month, and they wouldn't let me go because I was on contingency orders. So I had to call the school and say, "Hey, I'm deployed," kind of, not really, but yes. Can I hold my seat? And they said, "Hey, we'll just roll you over to next year. You don't have to apply again. We'll just activate somebody off the alternate list and let them come take your seat." So that's what ended up happening. And for any of you who don't think that things happen for a reason, I can tell you that sometimes they absolutely do. If I had been allowed to leave and start medical school on time, I would actually have been competing for residency with somebody who ended up being a big advocate for me to get into residency because he was a year ahead of me. We would have been going head to head, and instead we ended up staggered by a year. So I did medical school at Oklahoma State, took a health profession scholarship, commissioned as a second lieutenant. I was an E5 when I commissioned. 4 years in Tulsa and various other locations around Oklahoma for medical school, and then I matched to the urology residency program here at BAMC. Well, I did my internship at BAMC. The Army has a series of training programs across multiple different specialties where you can actually train in a high-volume civilian residency program, but it's considered an active duty training program. So I got time in grade, time in service, time towards retirement, all the benefits of being in an active duty training program, but at UT Health Science Center San Antonio. So I did all my training after my internship at BAMC in general surgery at a high-volume civilian residency program, which was awesome. Lots of trauma, lots of really, really, really sick people that you don't necessarily see in a relatively healthy military population, or even a relatively healthy military retiree population. And I'll just go off on a tangent here for a second. We'll talk about that more as we get further into the course. One of the conditions that we'll talk about in the urology section is urothelial carcinoma of the bladder. Bladder cancer is typically diagnosed at the age of 69. and the major predisposing factor is tobacco exposure, okay? In order to graduate from a urology residency program, you have to do a minimum of 8 radical cystectomies. That's one of the biggest whacks that you do in urology. It's taking out the whole bladder, taking a piece of bowel, turning it into either a continent catheterizable neobladder, like what Deion Sanders had done between football seasons, if any of y'all have been tracking that, or building an ileoconduit, which is like an ileostomy or a colostomy, except instead of draining stool to a bag on a person's side, it drains urine, okay? So it's a really, really, really big operation, okay? You have to do 8 minimum to meet residency graduation requirements from a urology residency program. How many radical cystectomies do you think they do at BAMC on average each year?
2.
I heard 2.
2.
2. That's how many. They do 2 per annum. How many years does a person spend as a chief resident in a residency training program? 1. So and so where I trained at UT, the University of Texas University Medical Center was our main training site, but the place that we spent the second most amount of time was at the Audie Murphy VA. Well, the only difference between VA patients and retirees at BAMC or any other military treatment facility is the retirees spent 20 years on active duty or in the reserves and retired and finally hit age 60, right? That's the difference between those two populations. Which population do you think is way sicker? The VA population. And the pathology that you see in a VA hospital is nuts. So I trained at UT, and then my first assignment out of residency was actually back at BAMC as staff. So I went from being a trainee one day to being a faculty member the next. It was a really wild transition because some of the people that I had been co-residents with who were still in training were now my students. And some of them had been general medical officers before they got accepted to residency, so they actually outranked me. But the buck stopped with me. This is something you will see as you get further into military healthcare. If you haven't yet, you'll find people that you have more responsibility than and have a higher level of credentialing than them, and they will have more rank than you, and that's where you can't let your authority and responsibilities get confused with rank, but that's a discussion for another time. Anyway, so I spent 4 years at BAMC as a staff urologist, and then by that point I'd been in San Antonio for like 9 years, and the Army said, you gotta go somewhere, you can't stay here. And my wife finished her emergency medicine residency at BAMC. She was in the Air Force. She got out in 2021, and the only place they could send us together was the National Capital Region. So we went to DC, and I was assigned to Fort Belvoir. My wife was assigned to Joint Base Andrews. We lived at Andrews, and I commuted to Fort Belvoir every day. And after I'd been there for a little less than a year, I was coming up on my primary zone 05 board, and I was looking at my record, and I was like, okay, so I was an intern, and I was a staff then I was a resident, then I was a staff urologist, then I was a staff urologist, then a staff urologist. No career progression, right? Not something that they like seeing at promotion boards. They like to see you continuing to move forward. And as it so happened, they advertised an opening for a chief of the Department of Public Health at Fort Belvoir Community Hospital. I have no background in public health, other than treating diseases of public health concern like chlamydia and gonorrhea. And so I applied for the position, not even thinking that they would even interview me. Well, not only did they interview me, they hired me. So the moral of the story is be careful what you ask for. I ended up as the chief of the Department of Public Health at Fort Belvoir Community Hospital, which provides public health support to not just Fort Belvoir, but multiple installations around the National Capital Region. We dealt with lead paint in post-housing, mold and air quality in post-housing, asbestos in the hangars for the Army Aviation Brigade. There was a whole bunch of stuff that was high profile that we got involved in. And from there, well, while I was there, I got the opportunity to go to the flight surgeons course, which isn't something that typically happens to somebody who's already been through a subspecialty surgical training program, but I'd wanted to do it since I was a medical student. And the Army wouldn't let me go as a medical student because they knew I wanted to be a urologist, and they said, that's silly, why would we send a urologist to the flight surgeons course? Anyway, I managed to get to do it while I was at Fort Belvoir because as the chief of the Department of Public Health, the Joint Medical Readiness Clinic fell in the same directorate, and they were short aeromedical providers. They only had one. And the only other section within the Department of Clinical Support that had physicians, well, there were two, the lab, so pathologists, and radiologists. How many volunteers do you think they got from those two sections to actually lay hands on patients? None, zero. I was the only one that said, I'll go if you send me. And so they sent me the flight surgeons course. It was great. If you have an opportunity to go to the aeromedical PA course, once you get through here, highly recommend it. It's a lot of fun. And so then I came back and started seeing flight patients when I wasn't seeing urology patients or dealing with lead paint and asbestos. And then I got a phone call from Human Resources Command saying, congratulations, you've been selected as the next command surgeon, Area Support Group Qatar. Cool. So I went to Qatar for a year, the first 6 months of which were awesome. If you've ever been to either Camp Asalea or Al Udeid, you'll know it's a neat place to get sent for a while. The first 6 months were awesome, and then COVID started. And who do you think was the only uniformed Army physician in the entire country when COVID kicked off? Me. So I became the Public Health Emergency Management Officer for the country of Qatar, for all U.S. forces assigned there, at least all Army forces assigned there. So we had to stand up a forcible quarantine facility. We had 700 beds in a warehouse that had been used for R&R for people coming out of Iraq and Afghanistan for like 2 weeks of R&R. They had a warehouse that had CHUs, containerized housing units, in it. And we turned that into a forcible quarantine facility. Can't tell you how mad people were to get off the plane at Al Udeid and say, we're throwing you in a warehouse for 2 weeks, have fun. Initially, we didn't have any way to feed them, so we literally pre-staged pallets of MREs inside this warehouse and said, we'll get hot meals to you when we figure out how to do that. In the meantime, have at it. It was the Wild West for a while. So I did 6 months of that, and then while I was deployed, the Air Force PCS'd my wife back to BAMC. Well, the Army hadn't been planning on me going anywhere other than back to Fort Belvoir. So then they had to figure out how to get me to San Antonio, and I'm a general urologist, okay? I did a urology residency and no fellowship after that. So in urology, there's multiple additional training programs you can go to subspecialize in things like urologic oncology, endourology, stone disease, pediatric urology, things like that. And I didn't do any of those things. I'm just a general urologist. And BAMC has one position for a general urologist, and it was occupied by one of my former medical students, so that wasn't an option. But because I had gone to the flight surgeons course while I was at Fort Belvoir, there was a position at Army North Headquarters that had been vacant for 14 months during the COVID pandemic. And who knows what Army North did during the COVID pandemic? Anybody who hasn't already heard the story from me before? Army North is the Army component command under NORTHCOM. So anything that NORTHCOM gets involved in that happens on the land falls under Army jurisdiction. It becomes the Joint Forces Land Component Command, or the JFLC. So Army North, whose headquarters is here at Fort Sam, was the headquarters responsible for putting uniformed military personnel in any civilian institution that needed uplift during COVID. They ran the entire operation. And their one billet for a physician was vacant during COVID, which is why they had so much reserve uplift. But that position was hard-coded for occupational medicine. Am I an occupational medicine physician? Mm-mm. But Human Resources Command squinted at me really hard and said, well, you're an occupational medicine physician for aviators. You'll do. And so I got sent to Army North to fill an occupational medicine billet. And I did that for almost 3 years. Through COVID, through the Afghan evacuation. If you want to know what it's like to have to try to write a policy on refugee immunization, come talk to me. I will help you out. I will hook you up. There was nothing. The CDC didn't have anything in writing on how to do vaccination for pandemic illnesses in a refugee population at all. So we had to make it up. And we used CDC policy in other areas to help do that, and also DoD policy. But it was the Wild West for a while. So I was there for almost 3 years. Applied to and got accepted to the Army Baylor MHA MBA program here at MedCOE. Did that for a year. If you're ever interested in pursuing that, it is an option for PAs. It is tri-service, so any of you can potentially do it at some point in the future. If you'd like to get your Master's in Healthcare Administration or your Master's in Business Administration, you can do that. I don't recommend doing it the way that I did it, which is the 1-year Executive Clinical Leadership track, because that's 87 graduate credit hours in 12 months, including an administrative residency, all at the same time. It sucked, but I made it. And then I spent a year working for General Murray when he was the CG here under his Chief of the Medical Corps hat, working in the CHSBO's office. And if you don't know what that means, you're not unique. Most people don't know what a CHSBO is. It's the Corps Specific Branch Proponency Officer. And every corps within the AMED has one. So there's a CHSBO for the Specialist Corps, there's a CHSBO for the Vet Corps, et cetera. And I worked in the Medical Corps CHSBO's office. And while I was doing that, Colonel Douglas, who at the time was the dean of the graduate school here, approached me and said, "Would you like to teach in the IPAP program?" And I said, "Yes, I would love to," and so here I am. So that's how I got here. That's my weird, complicated, non-typical path that got me on, to this lectern in front of you all today. And again, all that, I tell you all of that because if you have questions about things that are not related to nephrology or urology or the Army, I may have an answer for you. I've worked in the joint space a lot, having been in Army North. The program, the Army Baylor program is joint. And I was born at the Air Force Academy. I'm an Air Force brat. That's my other disclaimer. My parents were both Air Force officers, and I ended up in the Army. But my birth certificate actually says, for city of birth, Air Force Academy, because at the time, the Air Force Academy had a full-service hospital on the Academy grounds, and if you were born on the Academy grounds, that was your city of birth. I've had to explain that to so many background investigators when I've had my security clearance renewed. So that's a little bit about me. As I mentioned, I enlisted when I was 17. That's me at my basic training graduation there on the left side of the screen. And then me finishing the Army Baylor program in the middle. And then on the right side is me in residency doing what's supposedly my day job, which is actually doing urologic surgery. And then my grandfather was an Army chaplain for 29 years. He was enlisted first as a chaplain's assistant and then went to seminary and came back. So that's him in the upper left when he was deployed with the 4th Infantry Division to Vietnam. My dad and my uncle are on either side of me there in the middle upper picture. My dad retired from the Air Force as a lieutenant colonel. He was a missileer, Titan II, intercontinental ballistic nuclear missiles. In the top right-hand corner picture, I'm actually in it, you just don't know it. My mom's pregnant with me in that picture. That is an Air Force maternity smock circa 1980. And then below that picture is my wife when she was deployed to Jordan. Oh yeah, so she was deployed to Jordan when I found out I was going to Qatar. So I had to call her on FaceTime and tell her that when she got back, we were going to be together for a matter of weeks, and then I was leaving for a year. And she hung up on me and didn't talk to me for like 72 hours. But it ended up being a good thing because it forced the Air Force to bring her back here, which is what she wanted anyway. And then bottom center is me reappointing her as a captain when she graduated from medical school, and bottom right is me when I was getting ready to leave for Qatar. So why do I do what I do? Well, these are my kids. Top left there is my oldest daughter, Lilith. She's 9 now. This is the day she was born. But she's 9 and in 4th grade. The bottom left-hand picture is my middle daughter, Roman. She's in 2nd grade. And then next to her is my son, Damien. He's a kindergartner this year. And then you can see in the center there, that's all of them a little bit older. It's still a little bit of a dated picture. So part of the reason I do what I do is for my family, and for everyone's families really to protect the United States. But on the right side, you'll see the other reason I do this is for the warfighter, right? So the bottom right-hand picture was our trauma bay at the Troop Medical Clinic at Camp Asalea. We had a roll 1, that was it, which is where a lot of you are likely to end up when you get out of here, at least initially, is at the roll 1 level of care. And you may not have a whole lot of resources available to you to get things done, but you'll have to figure it out. And then the picture above that, top right, that's in the quadrangle here at Army North Headquarters here at Fort Sam Houston. It's a little hard to tell from the size of the picture, but this gentleman in the middle here, that's Surgeon General at the time, General Dingle, and he was there to recognize us for the work that we did during COVID and Afghan withdrawal. You do it for the people on the right and left of you. As far as how the course is going to go, so this is the tentative course schedule. It is on Canvas, okay? And full disclosure, I inherited this course, okay? I'm going to make it my own as we work our way through it, but I didn't have a whole lot of time between joining IPAP and having to get up here on the podium to make a whole lot of modifications. So if we find issues with any of the slides as we're going through, the slides are what the slides are. They're all on Canvas already, okay? What's on the slides is what is testable material, okay? So when I go off on a tangent and some wild story about something that I saw or did, not testable, okay? It will not be on the exam, all right? But the slides that are already available on Canvas for the whole course, that's what the testable material is. And I will do my best to let you know if you need to be paying extra attention to something while I'm talking about it, okay? But we're gonna go through all the nephrology stuff first with a little bit of crossover. There's a few things like imaging studies bleeds into both areas. For whatever reason, the folks that were doing this course before me put all of the malignancies under nephrology. Nephrologists don't take care of genitourinary malignancies, urologists do. But it is what it is. Just today, I found an error on one of the slides that we're going to have up here today, which was, who can tell me what GFR stands for? Right, it's not glomerular function rate. That's what the slide said. So anyway, if you notice something that doesn't look right and I didn't catch it, let me know. We'll get it fixed for the next group that comes through. But the slides are what the slides are as far as testable material. The exam is what the exam is. There will be 2 exams, one at the end of the nephrology block, one at the end of the urology block. The schedule is what the schedule is. I know that it is prone to change frequently. At least that's what I've been told. So we'll take any schedule changes as they come. I am not planning on being anywhere else than here, so if there are changes in the class schedule that forces one of our class blocks to get moved to another place, it won't be because of me, unless something unexpected happens. I was notified today that I've been identified as a court-martial panel member for like the big pool, right? So I could get called for jury duty, but we'll see what happens with that. So any questions about the course? Oh, the syllabus. So the syllabus is up. It's not going to change except for the course instructor, right? So there's a block on the syllabus, for signature for the course instructor. Once I'm able to get that in an editable form, I will remove the previous instructor's name and sign it, put it back up, but nothing else about the syllabus is going to change, okay? At least not for now. I understand that all of the syllabi for all of the courses are going to be going through some fairly significant revision over the course of the next year to get them in line with what ARC-PA wants to see. But it won't have any effect on you guys as far as like how the course is administered. Okay? Questions? All right, let's get started on nephrology. Yes, the slides are boring. They're white. There's no pictures. I'm sorry. I'll fix that at some point. But this is they're very vanilla, and this is just what we're going to have to deal with. So I'm sorry if it hurts your eyes. It hurts my eyes looking at them. Oh yeah, one other disclaimer. I'm a prior service combat arms guy, right? So I might accidentally drop an F-bomb here or there. If that offends anybody, please come talk to me about it. It won't be intentional. It certainly won't be aimed at anybody individually, but full warning, it could happen. All right, so today what we're going to spend the rest of the time talking about is assessment of kidney disease, laboratory investigation, and renal imaging. This is sort of a broad overview. There are things that are covered in these slides that will be covered in greater detail in later lectures, okay? So don't get too hung up on the details if we go through something relatively quickly. There's slides in here that talk about calculating a fractional excretion of sodium. We'll get to that in more detail in later lectures, okay? So this is meant to be sort of a broad overview. And like I said, if there's something on any of the slides that needs to be emphasized, I'll try to let you know. And there will be a review session prior to each exam where we'll go over the things that you really need to pay attention to before the exam. Really, my main goal for all of you coming out of this class is to give you an idea of what right looks like from a renal and urologic standpoint, and what looks wrong, and what road you should go down to try to figure that out a little bit further. Okay, again, I'm not trying to turn you into a nephrologist. They're all weird anyway. And I mean that in the nicest way possible. They're great people, but they're weird. And I'm not trying to turn you into a urologist. Who can tell me the difference between nephrology and urology? Anybody?
Nephrology, specifically the kidneys, urology, the whole system.
So that's sort of right. I heard another one over here. What was it?
I don't know if it's the same thing you said. I thought the kidney, or like nephrology is kidney specific, urology is the.
Okay, so that is what he said. So that's part of it. All right, so nephrologists concern themselves with medical diseases of the kidneys. All right, so nephrogenic hypertension, acute kidney injury, nephritic syndrome, nephrotic syndrome, IgA nephropathy, chronic kidney disease, end-stage renal disease. Anything that you would treat with medication or dialysis basically falls under the umbrella of nephrology. If it involves the urinary tract or the male reproductive system, and it can be fixed with surgery, generally it falls under urology. Okay, so urologists are genitourinary surgeons. In fact, that's what they used to call them back in the day before they came up with the term urology, was they were genitourinary surgeons. We actually still have a few professional societies that still exist from way back in the day that still call themselves the Society of Genitourinary Surgeons. So that's the big difference, is if it's a medical problem and it involves the kidneys, it's nephrology. If it's a surgical problem and it involves the urinary tract anywhere along its course, or the male reproductive system, and in a few instances the female reproductive system, we do hysterectomy sometimes, then it's urology. All right. So we're going to talk about the kidneys and their function. I am going to assume that I don't need to review very much renal anatomy with you. I hope you guys got that during your first semester in A&P, both from a macro level down to a micro level. But we will talk about kidneys and function. We'll talk about some presenting features of renal disease, initial laboratory investigation, and there's one slide on renal biopsy, which we're not going to cover very much, and then we'll talk about kidney failure, common kidney diseases. The part that I'm really probably going to put the most emphasis on, though, for this first lecture, though, is going to be the imaging. I think it's the area, at least as far as this first lecture goes, where you can get the most bang for your buck, and it's definitely something that a urologist deals with a lot. So hopefully I can give you some tips and tricks for urologic imaging studies. And if at any point there's a question, please raise your hand and speak up. You don't have to wait for me to take a break or get to the end of the lecture. So learning objectives, correctly analyze and interpret information pertaining to the genitourinary system obtained from various serum studies and urinalysis reports. Do I need to tell you where the exits are and where the bathrooms are? Are we like that heavily trade-off? Okay, cool. All right, so we're also going to compare, contrast, and correctly apply the most common imaging studies for the genitourinary tract, right? And again, all this is on Canvas. All right, these are kidneys. Step one, identify the kidneys. Bean-shaped organs, posterior wall of the abdomen. You see here what the average normal size is for the kidneys. Hopefully you knew that already. Functioning units called nephrons. Hopefully you knew that too. So you got the tubules and the glomerulus. And here is a schematic diagram of a single glomerulus with its associated proximal tubule, loop of Henle, and collecting tubule, and some of the various electrolyte and hormonal influences that occur in those areas. So, who can tell me what the kidneys do? What is the function of the kidneys? Okay, it's a filter. What else? What else does it do? Okay, so it helps with fluid balances, blood pressure. Okay, yeah. So it's a filter, but it also has some endocrine function as well that is actually part of the kidney, as opposed to the things that come from the adrenal gland, right, which are on top of the kidney but separate from. Okay. So removal of waste, excess water from the body, regulation of fluid electrolyte and acid base balances, as well as blood pressure regulation, stimulation of production of red blood cells, and helping with vitamin D regulation to maintain normal bone structure. So all these things are very important, and all these things can get thrown out of whack in people that have, for example, end-stage renal disease. So a problem with people with end-stage renal disease is if you're talking about an elderly person, they already have issues with osteoporosis, osteomalacia, right? It's way worse when their vitamin D regulation is all jacked up and they have an acid-base dysregulation, like they're actively dissolving their bones while they're sitting there in front of you. So these are other things about kidney function that you have to take into consideration. All right, so we're going to talk about urinalysis. We're going to talk about renal function tests. We're going to talk about renal biopsies, and then we'll talk about imaging. So, by show of hands, how many people have actually looked at a urinalysis before? And when I say looked at a urinalysis, I mean put urine on a microscope slide and looked at it under a microscope. We got one hand. Any others? Any lab people in here? There. I got another one. Okay. Highly, highly, highly encourage all of you that if you have the ability to actually look at urine, do it, okay? And I know that sounds like a weird phrase for somebody to say. If you have an opportunity to look at urine, you should do it. But you may find yourself in a situation where the only laboratory capability that you have for urine is a dipstick. And a dipstick is helpful, but a dipstick is also woefully inadequate compared to what you can do with a simple microscope. So if you have access to a microscope at your roll one somewhere out there in the future, and you don't have immediate laboratory services, like everything else is a send out, and for UAs you just do a dipstick, if you have microscope slides, put that urine on a microscope slide, put a slip cover on it, and look at it yourself. You can learn so much about what's going on with a patient by actually looking at their, you don't have to have access to stains, you don't need H&E, you don't have to be able to fix it. All you got to do is put it on a slide and stick it under a microscope and look at it. And there's so much that you can learn about what's going on with the patient. And you may learn things that help you rule in or rule out other things that you find on a urinalysis dipstick. For example, if the dipstick is positive for blood, does that mean that there's actually blood in the person's urine? No. Lots of things can cause the blood, it's actually hemoglobin, the hemoglobin box on a urine dipstick to trip positive when it isn't actually positive. All right, so being able to look at it under a microscope and go, there's no red blood cells here. Why is this positive on the dipstick? Can go a long way to helping you figure out what's going on with the patient. Or it can make things more confusing and make you say, well, we need to send this person to a higher level of care because I don't know what's going on. All right, so urinalysis. First morning specimen preferred in certain circumstances. We'll talk more about that later. But the key thing about urinalysis collection is that it needs to be a midstream clean catch. Who can tell me what a clean catch means? Right. So you want to make sure that the area is clean before urine is collected. It's easier for males than it is for females. They do make specialized urine collection devices for females to do urinalysis, but even with that, it's still very, very challenging to do a clean catch urinalysis. Excuse me, for women. And then forget about kids. In some situations, if you're talking about an infant, the only way you're really going to get a clean catch urine on them, well, you're not going to be catching it. You're going to catheterize them, or how else can you get urine from a baby? Yep, percutaneous aspiration, suprapubic. Stick a needle in their bladder and aspirate the urine. Which sounds horrible, but it's actually a whole lot simpler than it sounds. So if you, this is one of those things that you're not going to see on a dipstick, is signs that maybe a clean catch wasn't accomplished appropriately. So if you look at a urinalysis and you see epithelial cells in the urine, are there supposed to be epithelial cells in the urine? No. Are there epithelial cells inside the urinary tract? Not squamous epithelial cells. There better not be. If there are, you have a problem. So if you see squamous epithelial cells, then you know it wasn't a clean catch, right? So, but that's not something you're going to see on a dipstick. Another reason to look at urine under the microscope, because that'll give you an indication as to whether or not the catch was performed appropriately. So if you see squamous epithelial cells on a urinalysis, it should probably be repeated, right? Yes. Okay. The container should be sterile. If you have any ability to put things in sterile containers, which in an MTF you should be able to. And then if there's going to be any length of time between the collection and making it to a lab, that needs to be refrigerated. Bacteria love urine. Normal urine, diabetic urine, it doesn't matter. They love it and they multiply in it like gangbusters. So you don't want to leave it unrefrigerated. So methods of urine collection, we've already touched on this a little bit. So midstream urine. If you're doing a urinalysis or you're instructing someone on how to do urinalysis, the idea is you start urinating into the toilet and let it go for a little bit and then start collecting it, because you're more likely to wash any cutaneous contaminants off during that initial stream so that they're out of the way before you start collecting. And you want to clean the meatus as best you can before you start doing that too. So with an alcohol prep pad or whatever the lab has to issue out for cleaning. Bag collection, not a great way to do it. If you're not concerned about infection and you just want to look and see what's in an infant's urine, you can put a bag on them that is affixed with adhesive until they urinate into it, and you can look at it. But you shouldn't do that for culture collection, because it's going to be contaminated, and you can't trust whatever grows or doesn't grow. And you shouldn't do it for microscopic exam, unless you're looking for things that are not related to infection, like casts. Catheterization happens more frequently than you might think, it can be done it's often necessary to be done in children. It's often necessary to be done, in elderly people who may be suffering from dementia and can't be instructed to urinate on demand, or people that are obtunded. And then suprapubic bladder aspiration can also be done in adults. It's not just for children. The situations in which you might need to do a suprapubic bladder aspiration in an adult are few and far between. It's actually a lot easier to put a catheter in them, particularly for fat, but it can be done. So urinalysis, here's the famous urinalysis dipstick. If any of you have ever checked the chlorine in your pool, it's very similar. You take the dipstick, you dip it in the urine, and then you compare it to the color boxes on the outside of the bottle. Unless you're really lucky and have an automatic urinalysis machine that is appropriately calibrated, you just put the dipstick in it and it will spit out the results for you and tell you what's positive and what's not. But again, you have to take all these things with a little bit of a grain of salt, because there are things that can be false positive, false negative. And generally speaking, these are the things that you will see tested for on your standard urinalysis dipstick. So for gross examination of the urine, again, it can be helpful to actually look at a person's urine. What does it actually look like? Is it a normal color? Is it an abnormal color? Is it normal for urine to be the color of Coca-Cola? No. Can it be the color of Coca-Cola? Yes. Just it being the color of Coca-Cola, does that tell you what's wrong with the person? No, but it narrows it down considerably, so being able to look at it is helpful. There's some weird conditions out there that can cause some really strange urine colors as well. And then turbidity, that's just, is it clear or not? Is it clear, is it cloudy, right? And turbidity in and of it by itself doesn't really tell you anything. It can potentially be a sign of something wrong, but you can have somebody who has turbid urine and has nothing wrong with it. As it says here, not a reliable method for determining precise pathology. And then odor. Yeah, you can smell the urine and see if it doesn't smell right. But just because it doesn't smell right doesn't necessarily mean that it's going to tell you exactly what the problem is. Excuse me. Infected urine can smell bad. Excuse me. But so does the urine of somebody who has asparagine in their digestive system and has just eaten asparagus, right? So just having strange smelling urine doesn't necessarily tell you anything about it. All right, so specific gravity of urine, the normal range is between 1.005 and 1.030. There won't be a whole lot of instances where looking at the specific gravity of urine is going to be of particular use to you outside of an academic setting. Most of the time, there's other things you're going to look at that make you go, wow, this person's tonicity is way off. They're volume overloaded, they're volume depleted. You're not probably going to be looking at the specific gravity. The one place that comes to mind where specific gravity can be useful is if you are the medical review officer for a unit that and you're reviewing results from command-directed drug screens. If somebody's specific gravity is really, 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 really low, that means that they were trying to hammer the fluids before they did their UA, either because they didn't know they were doing one and they had to hammer fluids to be able to pee at all, or because they're trying to dilute their urine out big time so that it doesn't pop positive. But otherwise, specific gravity isn't necessarily one of the things that you're gonna look at in a clinical setting, unless you're a nephrologist, and none of us are. It can help provide information on urine osmolality, but if you have other laboratory parameters available to you, you're going to be looking at those things to help calculate osmolality and give you an idea of what the person's volume status is. If all you have is a dipstick and it has one of the panels for specific gravity, it can be helpful. Urinary pH. Urine can be acidic or it can be basic. That's heavily influenced by how much a person has been consuming fluid-wise, and also what they've been eating and or drinking. And whether or not they're sick. There's things that can cause significantly low urinary pH, like some examples here on the slide, like diabetic ketoacidosis, diarrhea, starvation, or renal tubular acidosis. Other medical conditions can affect the pH in urine. Protein. You really shouldn't have protein in the urine. Occasionally, you can see low levels of protein in a person who's otherwise normal, but you really shouldn't be seeing large amounts of protein in urine, and that will show up on most urine dipsticks. But it doesn't tell you what protein. So it's not going to tell you, is it albumin, is it something else? That's where if you see high levels of protein, you're going to want to get more definitive studies on those patients. And glucose, under normal circumstances, should you see sugar in anybody's urine? No. Is it bad to see sugar in people's urine? Yes. Which is why it blows my mind that we now have diabetic medications out there that actually cause people to dump sugar in their urine. Like, I think Jardiance is one of them. It is not good for your glomeruli to be passing sugar through them. They're not designed for that. And if you've seen any of the commercials on television where they say, this can cause a or potentially increase your risk for a significant skin infection in the genitals. Who's heard that on the disclaimers before? Am I the only person that pays attention to that? Okay, I got a couple hands. We're talking Fournier's gangrene, okay? We're talking about polymicrobial necrotizing fasciitis of the genitals, which loves sugar. And so, yeah, having glucose in the urine, bad under most circumstances. But it is also something that you need to be aware of to ask a patient about. If they didn't tell you everything about their meds and they've got sugar in their urine, it may not necessarily be an indication that they're a poorly controlled diabetic. They may be well controlled on medication that causes them to dump sugar in their urine. So proteinuria, nephrotic syndrome, nephritic syndrome, we'll talk more about these in greater detail in later lectures. Just understand that they exist, nephrotic syndrome, nephritic syndrome. The mnemonic device that I learned in medical school to help differentiate between nephrotic syndrome and nephritic syndrome as far as it pertains to protein in the urine, you'll see high levels of proteinuria in nephrotic syndrome, and the way you remember it is the O in nephrotic is like a big open manhole cover and proteins just pouring through it, okay? So nephrotic syndromes are usually associated with high levels of proteinuria, where nephritic syndromes aren't necessarily associated with high levels of proteinuria. Excuse me. Ketones, you shouldn't see ketones in the urine on a regular basis unless somebody is starving themselves or is on a diet that induces ketosis. Blood is never normal in urine from a urologic source. Now, I say that because it is possible for urine to be contaminated with blood from other sources, such as menses, but there shouldn't be blood in normal urine. In a person with a normal urinary tract, you shouldn't see blood. So sources of blood can include trauma, malignancy, medical renal disease. So nephrotic and nephritic syndromes can cause red blood cells to get out through the walls of the glomerulus and into the collecting ducts. And this is, again, we get back to the point that a dipstick doesn't necessarily tell you if there is intact blood, red blood cells in urinalysis, or in urine on a urinalysis, which is why it's important to do microscopy and look. And we'll talk about what you do when you find blood in the urine later on. Most of the time it's referred to urology, but not always. Sometimes it's referred to nephrology. So urobilinogen, it's normal to have a trace of it. If you see high levels of urobilinogen or bilirubin, that may be a sign of liver failure. Something to key on if you see it. Leukocyte esterase, as like the slide says, it's an enzyme produced by neutrophils. It can be a sign of infection, but just because you see leukocyte esterase being positive on a urinalysis does not necessarily mean the person has an infection. Leukocytes can be in the urine for other reasons besides infection, to include contamination, a poor catch. So resist the urge, and this is the urologist in me speaking, resist the urge to throw antibiotics at somebody just because they have positive leukocyte esterase on a urinalysis, especially if they don't necessarily look sick. If it's an incidental finding, they may not necessarily have a urinary tract infection. Leukocytes are found in extremely high quantities in normal vaginal secretions. So again, we get back to the whole, was this a clean catch or not? You can have positive leukocyte esterase without there being an infection. Now, if it's nitrite positive and you don't have a reason for a false positive, then they probably have an infection, because nitrite positive urine is caused by gram-negative bacteria metabolizing chemicals in the urine. Okay. Now, if they have bacteria that's not gram-negative, then it may not be nitrite positive, and they may still have a urinary tract infection. But if you do see nitrite positive urine, then they probably have an infection. Two of the biggest false positives, and this is just something to put in your back pocket and just remember, this is not on the exam. On a dipstick, the box that changes color for nitrite positive is orangish red. Okay? So if they have gross hematuria, if they have visible blood in their urine, it may turn that box a positive color without it actually being positive, okay? And the other thing is, who knows what pyridium is? Okay, we've got a few hands. All right, so pyridium, you can buy it over the counter. The brand name's Azo, okay? It's a urinary analgesic that is given for dysuria, usually associated with urinary tract infections. It turns the urine bright orange. Bright orange. It is the same color as a positive box change for nitrites. And so that can really confound things, right? If you have somebody who has dysuria and they bought some over-the-counter Azo to help with their dysuria, and you do a dipstick on them, do they have a urinary tract infection or not? Are urinary tract infections the only thing that cause dysuria? No. So just some things to keep in mind. Really, truly, the only way to know for sure if somebody has a urinary tract infection is culture. That's really the only way to know for certain. Otherwise, you're just basing it on clinical signs. All right, so urine microscopy, yes?
It's our time for break.
Okay, take a break. Stay on track. So as I mentioned, looking at the urine under a microscope can be very, very helpful. You see the slide here refers to it as a poor man's renal biopsy, because it can be. You can see renal cells. It's not normal to see renal cells on a normal urinalysis, but if you do see them, it can give you some idea of what's going on with the patient that's in front of you. And we already talked about what a clean catch midstream sample is. So things that you may see on microscopy in the sediment. Oh, so here's the other thing. If you have access to a centrifuge, you should always centrifuge the urine before you look at it under the microscope. If you don't have access to a centrifuge, that's okay. Just get a pipette and put it on a slide as best you can. But if you have access to a centrifuge, what you want to do is you want to spin the urine down so that whatever sediment was in it settles to the bottom, and then you quickly dump the tube and tip it back upright again so that a little bit of urine remains in there for you to actually be able to pipette the sediment that's on the bottom. And then you put that on the slide and look at it. It's higher yield that way because it concentrates all of the sediment in one place rather than you having to move the slide all over the place. Oh, there's one red blood cell. You move all the way to the other. Okay, there's another one. And so it makes it more high yield. But things that you may see in the sediment are red blood cells, white blood cells, casts. Casts are just as the name implies. It is a cast of an internal renal structure. So if you think about casting jewelry or casting gold bars or whatever it is, you put something into a form and it hardens there, and then you take the form away and you're left with a cast, right? As opposed to a cast that you put on somebody's arm or leg because they broke a bone. And casts can be made up of various cell types, which can give you an idea of what's going on in somebody's kidney. So if you see casts that are made up of renal parenchymal cells, actual renal cells, then that can be a sign of acute tubular necrosis. Their kidneys are dying, right? And the cells are getting jammed together in the renal tubules and the collecting ducts, and they cast together, and then they come out in the urine, and you can see those casts. That's just one example. Crystals. So there are charts in most labs where they do urine processing that will show you the various crystals, and they have different shapes based on what crystalline material you're looking at. We're not going to get into that level of detail, but I will tell you it is absolutely possible to tell what type of crystals they are by their shape. So if you ever see crystals and you're curious, you can get on your phone and get on Google and look at it and see what kind of crystals. Is this cysteine? Is it calcium oxalate, calcium phosphate? What is this? Because you can tell them apart without the need for chemical analysis of the urine, just based on the way the crystals look. And then you may see swimmers in somebody's urine if they have an active urinary tract infection or a sexually transmitted illness. You may see bacteria, you may see yeast, you can see I've seen treponemes in people who have syphilis. That's not typical, but I have seen it. You may see spermatozoa if there was sexual activity closely related to when the urinalysis was given. You may see it if sexual activity wasn't closely temporally related to the urinalysis, and that can be part of a fertility workup. That's talk for another time. Suffice it to say, seeing sperm in the urine isn't necessarily an abnormal thing. It can be a side effect of medication. It can be a side effect of surgery. But don't be surprised if you see sperm in urine. That doesn't necessarily mean that the patient did something inappropriate before they came in to see you in your office. Okay, so squamous epithelial cells. Like I said before, seeing squamous epithelial cells is indicative of contamination. You shouldn't see squamous epithelial cells in the urine. If you do, you should recollect the urine, okay? And make sure that they do a clean catch of some sort. If you have them redo it and there's still squamous cells, there might be something seriously wrong, okay? It is possible to develop squamous cell carcinoma of the bladder. That is a thing. It usually occurs in people who have long-standing stone disease, particularly bladder stones, or people who have a chronic indwelling catheter for a long period of time. The constant rubbing of a foreign body in the bladder causes transformation of the urothelium into squamous epithelium, and squamous epithelium is not supposed to be underwater all the time, and it can turn malignant, okay? That will not be on the test. Just something to keep in mind, that if you continue to see squamous epithelial cells on a urinalysis that you know was done correctly, or you had them catheterized, and they're still squames, maybe a problem. Transitional epithelial cells, also referred to as urothelial cells, or occasionally you'll see that abbreviated TCC for transitional cell carcinoma, or UCC for urothelial cell carcinoma. They mean the same thing. And transitional or urothelial cells are found in the bladder, the ureters, and the renal pelvis. Okay, that's where they are normally located, is in those regions. So the lining of the bladder, the lining of the ureters all the way up, and then the renal pelvis, where the urine actually collects before it drains down, are lined with transitional cells, and you may see them. I know the slide says if you see large clumps of them, confirm with urinary cytology. Don't do that. Send them to a urologist. Okay, let the urologist figure out what's going on there. We don't use urine cytology as part of the normal routine workup for somebody who's being referred for the initial evaluation of possible neoplasm, because the sensitivity and specificity is not there. But seeing large numbers of urothelial cells, not necessarily normal, send them to your urologist. All right, so here's your renal tubular epithelial cells. We're talking about tubular necrosis and interstitial nephritis. This is what they look like. And if you see these, it is clinically relevant. You're probably not going to see them in a vacuum. The patient's going to come in with other complaints. They're not going to feel well. Maybe they've been taking a lot of nephrotoxic medications, or they were working out real heavy and not hydrating real well. They're not just going to walk in off the street looking totally normal, and you're going to find renal tubular epithelial cells in the urine, usually. Okay, so blood in the urine. Bottom line, send them to your urologist. Okay, that's really what it boils down to. Is if you see microscopic blood in the urine, and again, this is actually visualized red blood cells in the urine. If you refer somebody to a urologist who had positive blood on a dipstick and you didn't do a microscopy, they're going to be real upset. I mean, they're going to be real upset. They're going to probably give you some remedial training. Red blood cells in the urine, the thing that we worry about the most in the absence of other pertinent history like trauma is malignancy. Okay, red blood cells in the urine, unless they are dysmorphic. If the cells are dysmorphic, then that's typically a sign of medical renal disease, and the reason the cells are dysmorphic is because they got forced through a glomerulus. and traveled their way down the loop of Henle and through a collecting duct and finally got squirted out into the urine, and now they're all jacked up looking because they got forced through a tube. If it's a malignancy, the malignancy is releasing blood directly into the urine, okay? The tumor is bleeding, all right? And so there's no dysmorphia to those cells. So if you have somebody that you're looking at a urinalysis on and they have dysmorphic red blood cells, then you need to evaluate them further for medical renal disease like hypertension, IgA nephropathy, things like that. But if they don't have high blood pressure, the cells aren't dysmorphic, if they have a long tobacco exposure history, send them to urology because they might have a malignancy. The standards for evaluating microscopic hematuria have changed recently. You don't need to worry about that unless you're doing a phase 2 rotation in urology, in which case I recommend that you go to the AUA website and look at the guidelines for microscopic urine, microhematuria, microscopic blood in the urine, to see what the process is for working those things up, but it's more than you need to know here. If you're really curious about it, I'll be happy to talk to you about it offline. And like I mentioned at the beginning of the lecture, menstruation is a big confounding factor when it comes to finding blood in the urine. So if you have a patient who's female and is premenopausal and there's blood in the urine, make sure that they're not menstruating, and if they are, have them repeat the urinalysis or have them do it on another day. And then, like I said, the morphology can give you some idea of what's going on with the patient. Is it concerning for malignancy? Is it concerning for medical renal disease? When we get into imaging towards the end of the slide deck, this will make more sense, but if you have somebody who's experienced some sort of trauma, like a motor vehicle collision or an IED, and there's gross blood at the urethral meatus, should you try to catheterize that person? No. We'll talk more about that in a later slide. But no, please don't do that. The point is, if there's history that leads you to suspect that there is trauma, then go down the trauma pathway, right? Don't say, oh, this person just got extricated from a car after prolonged extrication after a bad accident. They've got microscopic hematuria. I wonder if they have cancer. Don't go down that road. Go down the trauma workup road. Leukocytes. So here's what your white blood cells look like on microscopy. If you have greater than 5 leukocytes per high-powered field, and you're satisfied that it was a clean catch and it was well executed and it's not contaminated, then that's technically considered pyuria. But pyuria does not mean infected, right? You can have pyuria without there being an infection present. Like it says here on the slide, stones, strictures, neoplasms, GU tuberculosis, which is a very specific infection. I'm not sure why we're calling that one out specifically, but how many of you knew that you could get tuberculosis in the urinary tract? Anybody? It's a thing. It was on my board exam. When I took my written boards after I graduated from residency, there was a X-ray that said, "Here's an X-ray. What does the person have?" And it was GU tuberculosis. The vas deferens gets calcified from the bacilli infiltrating the tissue, and it calcifies, and so you see these big loops going up over the top of the bladder. You hardly ever see it in the United States, but you might see it in the third world. And then, so yeah, if you have pyuria and there's no bacteria there, like you see a patient with pyuria, you send it off for culture, nothing grows, that's sterile pyuria. They had white blood cells, but it's not an infection. The point is, the presence of white blood cells does not necessarily mean that you need to throw antibiotics at somebody, okay? All right, here's a cast. So this is a red cell cast in a patient with glomerular nephritis, but you can see that the cells got mashed together and locked together with what's called tan horsefall proteins that cause them to keep that shape. And then once they came out of the collecting duct and ended up in the urine, this is what it looked like, okay? like it says on the slide, red cell casts can be an indication of glomerular infiltration. If you see red cell casts, it's probably not malignancy, okay? Here's a white cell cast, here's an epithelial cell cast, and we're talking about renal epithelial cells, not squamous epithelial cells, so this is what you might see in a case of acute tubular necrosis. Okay. And then fatty casts, so you might see what are called oval fat bodies associated with nephrotic syndrome. So if you see oval fat bodies on urine microscopy, you need to be thinking about nephrotic syndrome, okay? All right. There may not necessarily be fatty casts associated with it. You may just have the hyaline casts, which are just protein molecules that have been mashed together. So you'll see like this wispy, imagine the picture that's on the slide without all of the little yellow circles in it, okay? So you can still make out that there's a linear structure there. That's just the hyaline protein casts. But if it's got the oval fat bodies associated with it, then that's very pathognomonic for nephrotic syndrome. All right, and crystals, talk about this. If you really want to get into it, you can tell what is in somebody's urine, geologically speaking, if you want to put it that way, by the shape of the crystals, because all of those substances, the crystals are different shapes based on their chemical makeup, and you can tell what they are, but that's beyond the scope of this course. One type of crystal that is not listed here that I'll just throw out to you, again, not on the exam, but one of those weird, wacky things that occasionally happens. Some of the older generation HIV medications could crystallize in the urine and actually cause urinary obstruction like a kidney stone, okay? And so it's not common to see those things anymore because we have better things now, but if you have a patient who is getting their HIV treatment from a free clinic somewhere because they're indigent, they might still be putting them on one of these older antiretrovirals, like Indinavir was like the pathognomonic one, like that was the one that showed up on all the board exams. You have a patient with HIV who's on Indinavir and they have flank pain, they've got Indinavir stones. Oh, and by the way, Indinavir stones are radiolucent on all imaging modalities. You cannot see them on imaging. And so the only way to find them is to do a retrograde study and put contrast around them and figure out that they're there. So the point is there's weird crystals that can end up showing up in the urine that may be related to medication and aren't related to diet or other metabolic derangements. All right, organisms, bacteria. We're not going to get into all the crazy wild bacteria that you can see in a person's urine and how to identify them by their flagella and that sort of thing. Just know that you can see bacteria on urinalysis. And if you see things swimming around in somebody's otherwise well-collected midstream clean catch, they probably have a urinary tract infection. Always send your urine for culture unless you absolutely don't have the ability to do it. Always send a urine for culture, always follow up on your cultures. It's part of good antibiotic stewardship. I'm sure everyone in this room knows what a problem multi-drug resistant bacteria are and how hard it is for us to treat infections these days. Part of being part of the solution and not part of the problem is to not just reflexively throw empiric antibiotics at somebody. Occasionally you're going to be in a situation where you have to do that. Got it. Those situations are out there. You may be in a situation where you say, I'm really sure that you have an infection. I think this is what it is. I'm going to start you on antibiotics. Still send the urine for culture and make sure that you put them on something appropriate. You don't want somebody taking 2 weeks of antibiotics to do them no good, right? Because the organism that grew out wasn't sensitive. Maybe it would otherwise have been the right choice, but you have a resistant organism. You've done nothing to help the patient, right? So always send a urine culture, always follow up on it, and make sure your patients are on appropriately selected antibiotics so that they're only on antibiotics that they need to be on and only for a period of time that they need to be on it and help reduce the incidence of multi-drug resistant organisms. Yeasts, you will see yeast in urine. It's more common in diabetic patients that are poorly controlled or patients that are otherwise immunocompromised. Otherwise, you can see yeast as a contamination from a not well-performed clean catch. And the most common one is Candida albicans, but we're starting to see other species of Candida show up in urine that are more multi-drug resistant. Can you imagine having to put somebody on something like amphotericin B for a urinary tract infection? It happens, all right? There are other strains of Candida out there, other species that are very, very badly drug resistant. But the most common one that you're going to see is Candida albicans, and most Candida albicans is sensitive to your typical things like diflucan. And you can treat them with oral antibiotics. It is possible for people to develop fungus balls in their urinary tract. Again, we're talking about people that are either have an indwelling catheter or they're immunocompromised, but you will never clear their urinary yeast infection unless you get rid of the fungus ball. So if you have a patient that comes in to see you and you find yeast in their urine and you send it for culture and find out it's sensitive to diflucan, and you treat them with an appropriate course, and it doesn't go away, send them to your own, because they might have a yeast ball. Oh yeah, and just a note, I'm sure everybody knows this, but it's not uncommon for female patients to develop yeast infections after they've been on antibiotics. So a good thing to keep in mind, particularly if a patient tells you, hey, I'm gonna get a yeast infection after you give me this antibiotic, believe them, they know what they're talking about. Give them a single oral dose of diflucan to take along with their antibiotic to help make sure that they don't get a yeast infection as they're being treated for the urinary tract infection. All right, here's those oval fat bodies again. This is what those yellow circles that we saw on the previous slide, this is what they look like under polarized light. So if you ever see the phrase Maltese cross, they're oval fat bodies, nephrotic syndrome, okay? But just remember, oval fat bodies and nephrotic syndrome. All right, urine cultures, always send a urine for culture. 100,000 colony forming units is definitely positive. That is, yep, they've got an infection. But if they grow out a single organism that is something that is clinically significant, something that there's normally associated with urinary tract infections, and you're reasonably confident it was a well-collected midstream clean catch, then they probably have a urinary tract infection to treat them. Okay, as it says, correlate clinically. And again, it's not necessarily a reflexive order. It doesn't always happen automatically. Some urinalysis orders are built into the system where it is an automatic culture if the urinalysis looks abnormal, but not necessarily. And if you have some reason to suspect that somebody has a urinary tract infection, just order the culture. Don't depend on the lab to go, oh, this UA was normal. I wonder if they were thinking that the person might have a urinary tract infection and they don't end up doing that reflex microscopy and culture. Just order it. If you're getting a urinalysis on somebody, get a UA and a culture. And you'll be glad that you did. All right, so some definitions of renal disease. Azotemia just means the person has elevated blood urea nitrogen and creatinine. Uremia is when those when the BUN and the creatinine start getting real high and they're starting to cause systemic effects. So if you've ever heard of hepatorenal syndrome, so a person who's literally on death's doorstep because their kidneys have failed and their kidney failure is starting to cause other organ systems to fail, and the two organ systems failing are feeding off of each other and they get hepatorenal syndrome, that's uremia. I will also tell you that I had a faculty member in residency who used to say that uremia is not the bad way to go. Because it's not. If you have somebody who has decided that they don't want to pursue active medical treatment anymore and they're in renal failure, and they say, just pull the plug, just supportive care only, and they were on dialysis and they say withhold it, as those uremic byproducts start to build up in their urine, they basically just slip into a somnolent state and eventually die. and it's a relatively painless, peaceful way to go. It beats drowning or burning to death. End-stage renal disease is when your kidney function gets to the point that you require dialysis. Okay, so you can have somebody who has chronic kidney disease and has had it for an extremely long period of time, and that doesn't necessarily qualify as end-stage renal disease. If they need dialysis or they're on a transplant list, they have end-stage renal disease. All right. So blood urea nitrogen is a product of protein catabolism. You can see what the normal values are here. It can be elevated in dehydration, impaired renal perfusion. So if somebody was in septic shock or traumatic shock, you can see an increase in their blood urea nitrogen. It also goes up if they're just eating more protein because they want the gains. And then there's some medications that can cause it as well. You'll see it go down if they're overhydrating. And I don't know why it says renal perfusion there. Increasing somebody's renal perfusion doesn't necessarily reduce their BUN, but there it is. And liver disease can also cause a decrease in blood urea nitrogen because of the degradation in liver metabolism. Creatinine, product of muscle metabolism, and the thing that you really have to remember about creatinine, especially in the military population, is you will see completely healthy people who have what everyone else would consider to be an elevated creatinine because they work out a lot. If you're looking at somebody who looks like a power lifter, if they look like Terry Crews, they're probably not going to have a normal creatinine. We had a guy that worked in the IT department at BAMC when I was on the faculty there who was trying to donate a kidney to a family member in another state. And so he sent lab values that were drawn in Texas, and they initially came back and said, oh, no, you're in renal failure yourself. Like, your creatinine's 1.6. And he was like, no. I'm huge. And they said, we don't believe you. We want to see pictures. And so he had to send pictures to the transplant hospital, and he was huge. Like, this guy had muscles on his muscles. And they were like, okay, all right, you're fine. We're still not going to let you donate your kidney, though. But you probably don't have renal failure. So just keep that in mind. If somebody is very muscular, their creatinine is going to be higher at baseline. So it doesn't necessarily mean that there's something wrong with their kidney function. BUN creatinine ratio. The important thing to take away from this slide is the last bullet there, okay? The normal ratio for BUN creatinine is 10:1 to 15:1, okay? But look at the actual numbers that went into coming up with that ratio, okay? Because 100 to 10 is the same ratio as 10:1, but 100 to 10 is not normal, okay? So just keep that in mind. And like it says a little bit higher up there, if the ratio is increasing towards 20:1 or higher, then they may be dehydrated, right? All right, so glomerular function tests, there's a lot of ways to do this. There are multiple calculations out there that you can do to estimate somebody's GFR. Most labs will do it for you. You order a renal function test and they'll give you a GFR. One thing that's changed recently, they used to give you two different GFRs based on what they assumed the ethnicity of the patient was. And they didn't make any assumptions, so they would give you both, right? They would say, if your patient is African American, here's their GFR. If they're not, here's their GFR. And they don't do that anymore. That has been, you might still see some labs that still report those differences in numbers, but the standard, the clinical practice guideline, is to no longer estimate GFR based on ethnicity. And I think there's a bullet about that in one of these later slides. But you can see here one of the standard formulas for calculating GFR. You will not be expected to calculate a GFR on the exam, so don't worry about that. Just know how to do it if anybody asks you when you're on your clinical rotations. So you can see here what a normal glomerular filtration rate is, and they did take the ethnicity consideration off of this slide, but it does mention it later on. Measured versus estimated GFR. So when you order a renal function panel on somebody, the GFR that you're getting back is estimated. It's not the actual measured GFR, and it's impossible really to measure GFR in human beings. There are some additional tests that you can do to help figure out a better idea of what somebody's glomerular filtration rate is. But the most common way of estimating that is just to look at their creatinine. If they have a normal creatinine, they probably have normal renal function. If they don't have a normal creatinine, they either don't have normal renal function or they're after the gains. And so you have to look at the person holistically in order to make that determination. Here's another slide where it says glomerular function rate. That should say filtration rate. The two main regulation mechanisms are flow of blood in and out of the glomerulus and then glomerular surface area. So anything that affects those things are going to affect the filtration rate. So if the inflow and outflow of blood is constricted or liberated, the filtration rate is going to change. And if the glomerular surface area changes, which can occur in things like IgA nephropathy or other immunocompromised syndromes or autoimmune disorders, I should say, where you have things that are attacking the glomerulus and it's losing surface area, then those things can have an impact on filtration rate. Creatinine clearance is, again, it's a surrogate for how well somebody's kidneys are functioning. Look at the whole person, take it with a grain of salt. There are other ways to determine a person's renal function. Here is the most recent estimated GFR formula, and you'll see down at the bottom the bullet that talks about not assessing or not including race in diagnosing kidney disease because they've determined it's not accurate or necessary anymore. Excuse me. Here's some normal values for creatinine. And you can see it changes by age, starting with cord blood. That's what cord means. Cord blood on an infant that's still connected to the umbilical cord. Then newborn and through the ages until you get to adults, and you can see that the normal range goes up. So if you have a newborn, well, let me back up for a second. Newborn, 0.3 to 1.0. Why is that normal?
Still developing.
I'm hearing some mumbling, but I'm not hearing anything clear. I hear placenta. Elaborate, please. It's mom's creatinine. So in a newborn, their creatinine is potentially going to be higher initially because their blood chemistry studies are reflective of mom's blood chemistry studies. After a few days to a few weeks, depending on what chemistry study or hormone level that you're talking about, it should have normalized back to what it is for a newborn, which is why that range is 0.3 to 1, because it could be as high as 1 and then it'll come back down until they get bigger and start building their own muscle mass. Okay, so cystatin C is another way to estimate renal function. All I will say about it is that it's expensive, as it says on the slide. I have only ever seen it collected personally once, and that was on me. My primary care provider decided to order one on me. It's a blood test, and it is a more accurate way to measure a person's renal function because of how it's excreted. I would be shocked if you see a cystatin C level anytime soon. It's relatively new and it's really expensive, and under most circumstances, creatinine works just fine. All right, so fractional excretion of sodium is a way to assess kidney disease. I'm really going to breeze through this fairly quickly because we talk about this stuff more in greater detail later on. Just know that functional excretion of sodium is a way to determine whether or not a person's kidney injury is due to a pre-renal source, an intrarenal source, or a post-renal source. If their functional excretion of sodium is less than 1%, when you calculate it, then it is probably pre-renal, meaning they're probably dehydrated or there is some compromise to the blood supply to the kidney. So pre-renal, anything that occurs before the kidney. Intrarenal happening in the kidney, post-renal, after the kidney. And that includes the collecting system, okay? So in post-renal azotemia is usually a result of obstruction after the collecting system, or potentially in the collecting system. But if somebody has, like you have an infant with posterior urethral valves, which is a congenital abnormality that blocks the urethra, and they have gigantic bilateral vesicoureteral reflux. Or somebody who has bilateral renal stones, or an old guy with massive BPH that's obstructing his ability to empty his bladder and it's obstructed both kidneys, that's your post-renal, okay? So here you go. It's most helpful in oliguric states where they're not producing much urine anyway, but it's still helpful to calculate a fractional excretion of sodium to see if the person's problem is pre-renal, intrarenal, post-renal. Renal biopsies, the only people that do them are nephrologists. So unless you're on a nephrology service, you're probably not going to see a renal biopsy. It's a clinic procedure. It's not done in the operating room. They give them some local anesthetic in the skin overlying the kidney. They find the kidney with ultrasound, and they stick a TrueCut spring-loaded biopsy needle into the kidney through the skin and fire it, and maybe do that in more than one spot. Renal biopsies are, like it says on the slide, gold standard for diagnosis of glomerular disorders. Like if you want to diagnose somebody with IgA nephropathy, like definitively diagnose them, you need to be able to do an immunohistochemical stain on renal tissue and see IgA being deposited in the tissue. But that's about the only place you're going to see it. If you suspect that somebody has medical renal disease and you refer them to a nephrologist, the nephrologist is going to do whatever they think is necessary. You're not going to say, please consider renal biopsy in your referral. You're just going to say, patient has evidence of medical renal disease, uncontrolled hypertension, proteinuria, please evaluate, right? Just know that they can be done. It's an outpatient procedure. It's done in clinic. It doesn't require a trip to the operating room. If you're lucky, you might actually get to see one. Some radiologists will do them too. If they don't have a nephrologist at their location, then you might have a radiologist that does them procedurally as well. Okay, we're in the home stretch here. We're going to talk about imaging modalities in the urinary tract. This part is important because it spills over into both areas. So let me ask this question. Who's heard the phrase KUB before? Okay, I've got hands. Who knows what KUB means? Good! You'd be amazed the number of people that will say, I'm going to order a KUB, and you say, well, what's a KUB? And they go, I don't know, belly x-ray. It is specific for evaluating the kidney, ureter, and bladder, okay? There are other abdominal radiographs that don't necessarily get that entire field. So a KUB is a plain radiograph that evaluates the kidney, ureter, and bladder. The slide here says limited value for most kidney disease processes. That's true. The biggest thing that a KUB will do for you is it can help you follow the progression of kidney stone disease with minimal radiation exposure. Okay, so if you had somebody that came into the emergency department with flank pain and they're diagnosed with a ureteral stone and it's small enough that they might pass it on their own, if you're the person taking care of that patient in the emergency department, get a KUB also. It seems unnecessary, it seems redundant, but you're actually saving the patient radiation exposure in the future if that stone is visible on that KUB. So you got the CT scan that day, you know where the stone is on the CT scan, you get the KUB, you compare the two and go, okay, I think this shadow is the same thing. Now that person can potentially be followed with serial KUBs rather than having to put them in the donut of truth again and exposing them to the same radiation as 217 chest x-rays. A CT scan is not a zero risk procedure, all right? You are significantly raising a person's lifetime risk of a radiation-related malignancy every time you stick them in the donut of truth, okay? That doesn't mean you shouldn't do CTs. CTs are important and they're necessary and they help us diagnose things that we wouldn't otherwise be able to diagnose with, definitively, but don't automatically go to the CT scanner as your go-to unless you really, really need to. An IVP or intravenous pylography, this is almost not done anymore, okay? In fact, when I was at Fort Belvoir, they were ripping out the IVP tables to replace them with something else. To do a true IVP, there are actually specialized radiograph tables that the patient is positioned on that has bumpers that come up behind their flanks to bring their kidneys into maximum focus of the x-ray, and it makes everything else blurry. So what you see is the renal shadow. IVPs were how we used to diagnose renal masses before we had CT scan and ultrasound, because if they had a big enough renal mass, it would fill up with contrast, and you could actually see it. So contrast is injected intravenously, and then a series of KUBs on an IVP table are taken, and it shows, so there's a pre-contrast photo, and then there's one done every few minutes as the parenchyma starts to take up the contrast and the kidneys start to come into view, and then they get a phase where the contrast is coming up in the collecting system and draining down the ureters. And it can help you find obstructions in the ureters, which might be stones, might be a tumor in the lumen of the ureter. But like it says on the slide, it's almost been completely replaced by CT urography. It is a good thing to keep in your back pocket if you're someplace that doesn't have a CT scanner, but you do have ID contrast and plain X-ray. You can do a poor man's IVP even without an IVP table. So this is what an IVP looks like. You can see on the left side, there's a little bit of the renal shadow there on either side, and you can see the contrast coming down the ureters and starting to pool in the bladder. And then on the right side, you can see that one of the calyces is not very well defined. It's not filling out as well with the contrast right here, and so that's a filling defect. It could be a tumor, it could be a clot, but there's something there that requires additional evaluation. Renal ultrasonography is probably the most common renal imaging you will order because it's non-invasive, there's no radiation exposure, it tells you a lot about the renal parenchyma. You can identify renal masses on ultrasound. I say you can, it's not the gold standard for identifying renal masses, but you can see them. You can identify signs of obstruction in the form of hydronephrosis. A note on that, a person can have complete renal obstruction and have no hydro. A person can have a big blown out kidney and not have any obstruction. So hydronephrosis is a secondary sign of potential obstruction. It does not mean that they are obstructed. An ultrasound is not a functional study. And it tells you, one, are the kidneys there? How big are they? Is the parenchyma normal? That sort of thing. And you can do point of care ultrasound, or you can do a formal diagnostic ultrasound by ordering one from radiology and having an actual ultrasonographer come to do one. They are not equal. No matter how good you are, unless you are a certified ultrasonographer, even if you've done an ultrasound fellowship, the ultrasonographer is still probably going to be better at it than you are. Okay, I can do a renal ultrasound. I am not an ultrasonographer, and I would not consider myself to be better than a formally trained ultrasound technician. They are not equal. And then you can see here a list of advantages and disadvantages. Non-invasive, lack of ionizing radiation, relatively cheap, and then, again, highly dependent on operator skill. I have seen people in the beginnings of an ultrasound fellowship not even be able to find the kidneys. Okay, they're there. Person had 2 kidneys, couldn't find them. Right, so it is highly dependent on operator skill and the patient's body habits. If they're 2 or 3 HEB units, you may not be able to find their kidneys. Take it for what it's worth. You can see the kidney on the left. The renal parenchyma is darker in color. The collecting system and renal sinus fat, because it's lower density, is lighter in color. So the less dense the solid material, the lighter in color it's going to get. Unless you're talking about urine or water, it doesn't show up at all, right? It's zero density compared to everything else, and so if you see a big black area, that's probably a fluid collection of some sort, unless there's protein or blood in it, in which case it might be white because it's higher density. So the complete absence of something is going to show up as black. A lower density material like fat is going to show up white, and then your renal parenchyma is going to be black. And if they have medical renal disease, you can see there on the right side in the picture, the kidney looks whiter across the board. It's not as dark as the kidney on the left. It's not a slam dunk diagnosis, but it can be a sign of medical renal disease. And then if you're looking at the right kidney, the kidney should look different from the liver. You should be able to tell a difference. And you can see that there's a demarcating line between the liver and the kidney. They should have a slightly different density. If they look exactly the same and you can't tell them apart, then there's something going on there. All right, so again, hydronephrosis. You can see the kidney on the left is normal. The two kidneys on the right have big blown out collecting systems. But again, hydronephrosis does not necessarily mean that kidney is currently obstructed. If you have a person who as a child had a congenital obstruction to their collecting system and had a reconstruction of their UPJ, their uteropelvic junction, had a ureteroplasty, the distension in their kidney may never go away. It may never go back to normal. So it's an important piece of history to get. Just because they have a big blown out kidney with massive dilation doesn't necessarily mean that they're actively obstructed at that moment. Correlate clinically, right? But you can see here that the cortex of the kidney here is very, very thinned out. This is what you call grade 4 hydronephrosis. Here's bladder, normal bladder on the left. Bladder on the right happens to demonstrate a bladder tumor. Ultrasonography is not even on the treatment algorithm for evaluating people for bladder tumors, so don't think about it. It just happened to show up here as an incidental finding. Bladder tumors have to be pretty big for them to show up on a renal bladder ultrasound. The gold standard for looking for bladder tumors is cystoscopy, where we put a scope in a person's bladder. The scopes used to be stainless steel. They're now flexible fiber optic, and yes, both ways we did it without anesthesia in clinic. So keep that in mind. All right, transrectal ultrasound. You probably won't do a whole lot of transrectal ultrasound unless you end up working as a urology PA, which that's a thing. There's a urology PA at BAMC who's been a urology PA longer than I've been a urologist. He started working at BAMC after having been at the VA for years and years and years. The year that I did my internship, and he's still there. His name's Frank Stanley. If you ever run into him, say hi. He's a great dude. He does vasectomies. He has a whole day of the week that's blocked off for vasectomies, and he'll do like 12 of them. And he does prostate ultrasounds and biopsies as well.
5 out of 5 on deal.
Was that?
5 out of 5 on deal. Good job. He did this.
Oh, awesome! Yeah, Frank's good dude. Yeah. So you can see a transrectal ultrasound probe here. They can be done just for diagnostic evaluation of the prostate for things like infertility to evaluate whether or not somebody has obstructed ejaculatory ducts, or you can use it to help aim a biopsy needle for doing prostate biopsies for prostate cancer. All right, so CT scan. The CT is great for finding renal stones. It's great for renal masses, particularly with contrast. If you have a solid mass on ultrasound, a solid mass on CT that lights up with contrast, it is cancer until proven otherwise. Okay, remember that. I can't remember if it's on the exam or not, but this is like important for your clinical practice. If you do a CT scan with contrast of somebody's kidneys and they have a solid renal mass, as opposed to a cystic renal mass, if they have a solid renal mass that lights up with contrast, it is renal cell carcinoma until proven otherwise. Refer them to urology. Okay. There is a slide later on in here that says refer them to urology for consideration of a biopsy. We're not going to do that. We're going to take it out. That's what we're going to do. There's some articles in the literature that seem to indicate an increased risk of tract seeding by doing a percutaneous needle biopsy of renal masses. It's anecdotal, but it's bad enough. I mean, you want to give somebody renal cancer in their skin because you biopsied a renal mass when you could have just taken it out. like 99% of solid renal masses that light up with contrast are malignant. And there are some benign masses that look exactly the same as renal cell carcinoma on imaging. We take them out because that's the only way to tell for sure, is to remove them. And with any luck, it's a mass that's amenable to a partial nephrectomy, but if not, we take the whole kidney. So a CT urogram, this is what's really replaced an IVP. It's like any other CT scan with contrast, except it's done in phases. There's a non-contrast phase, then there is an arterial phase, which lights up the parenchyma of the kidney, and then there's an excretory phase. You want to talk about radiation exposure? This has a lot of radiation exposure, okay? So we try not to do them unless we absolutely need to. They are part of the workup for hematuria in certain situations. It used to be everybody who had microscopic hematuria got a CT urogram. We were radiating way too many people with way too much radiation, so now it's based on risk factors. But for gross hematuria, absolutely, they get a CT urogram to evaluate the renal parenchyma and the excretory portion of the urinary tract, the ureters and the bladder, for filling defects. Because just a CT scan with contrast isn't going to show you if there's any small masses in the ureters. You need that excretory phase to look for those filling defects to know if they have any upper tract abnormalities in the collecting system. MRI is useful for a handful of things, renal cysts. We don't really use it for diagnosis and staging of renal cell carcinoma. We primarily do that with CT scan, but it is an option for people that have a contrast allergy. If you can't give them IV contrast for some reason, then MRI is a good way to get around that problem. And it's also very useful for renal artery stenosis, which can be a cause of refractory hypertension. Like, you know, somebody who's on 3 different antihypertensives and they're still, you know, in the 180s over 90s, and then you do some imaging and find out that they have restricted blood flow to their kidney because they've got muscular hyperplasia of their renal arteries, causing renal artery stenosis, and then you treat that and the high blood pressure goes away. MRI can be done with contrast as well. You have to be careful in patients with stage 4 chronic kidney disease because they may not be able to clear the contrast, and they can end up with nephrogenic systemic fibrosis, where the gadolinium actually gets deposited in their soft tissues, which can look like this. It's bad, don't do it. And it can also potentially worsen their renal function. So keep an eye on what the renal function is before you give them contrast. But their renal function can be worse than somebody who you're considering giving CT contrast to. If they have questionable renal function, you don't want to give them CT contrast. If their renal function is not great, but it's not stage 4 CKD, you can still potentially give them gadolinium. When in doubt, ask your radiologist what they think, and they'll tell you whether or not it's a good idea or not. Then a very brief note on radionuclide studies. We're almost done, guys, I promise. You probably won't see too much in the way of radionuclide studies unless you're working in urology or in the radiology department for some reason. But these radionuclide studies include things like a MAG3 Lasix renogram, which actually provides you information on function and flow. So remember those ultrasounds we looked at before with the big blown out kidneys? And you want to know if the kidney's actually blown out? Like, is it obstructed now, or was it obstructed in the past? How do you figure that out? If you're the surgeon that did the ureteroplasty to remove the obstruction, and the kidney is permanently blown up, how do you know that you fixed the obstruction? MAG3 Lasix renogram. It uses technetium-99, which is used in a slew of nuclear medicine studies, and it's tagged to MAG3, which is mercaptoaminoglycoprotein 3, and it emits low levels of gamma radiation, and it shows up on scintigraphy. So it doesn't actually show the meat of the kidney. It's not like looking at a CT scan. You get these just sort of shapes that start to show up on a black field, and then the color starts to go down into the collecting system, then it drains down to the bladder, and they can actually time how long it takes to get from cortical phase to collecting phase to drainage, and they give a dose of Lasix at a point in that phase to see if there's normal washout. And if there's normal washout, then you know the obstruction's relieved. And it doesn't matter what their kidneys look like on ultrasound because they're working just fine. There's other types of nuclear medicine studies besides the MAG-3. There's one called the DMSA scan, which is used in kids who've had recurrent pyelonephritis. You can do it in adults too. It shows you whether or not they have any scarred areas in the renal parenchyma that are no longer functional and gives you an idea of how well their kidneys are still working. Renal arteriography or venography can be used to assess the renal vascular flow. This is before we had CT angiography and MR angiography. This is what you would have to do to see if somebody had renal artery stenosis. You'd actually have to invasively go up into their vascular system and put contrast in and take pictures to see if they had stenotic vessels. This is also something that can be done in somebody who has had trauma to their kidney. Usually it's blunt force trauma, like after a car accident, and they fractured their kidney. And you want to try to stop the bleeding and save the kidney. Your interventional radiologists can go in and embolize the bleeding vessels. And that's how they do it, is with angiography. So here you can see this is normal angiography here on this slide. And then you can see there's some renal artery stenosis there in the circle. Now this is not fibromuscular dysplasia, because in fibromuscular dysplasia you see what looks like a string of beads or a string of pearls. It's not just in one spot, but that filling defect you see there is where the artery is narrowed down and there's not as much blood getting through it, and it may need to be treated. And then you can see the same thing here. This is a 3D reconstruction of a CT scan that shows the narrowing of the artery there. Magnetic resonance angiography, same thing. Also very helpful for diagnosing renal artery stenosis, and it's less costly and invasive than going in, which is why we do this more now than actually doing invasive angiography anymore. But again, there's the risk associated with the gadolinium contrast. Okay, a little bit ago we talked about if you see blood at the meatus after trauma, do you pass catheter? The answer was no. This is why. If a person has a pelvic injury, they can have a disruption of their urethra, and if you try to put a catheter in, it may go who knows where. You can end up putting it somewhere in their pelvis. And the way you evaluate somebody for a urethral injury, it's not as common in women because the urethra is shorter and there's not as much tension on it between the pubic symphysis and the urethra, although it can happen. But in males, especially if they end up with a pubic diastasis where they have an open book fracture of the pelvis, it can tear the urethra. And the way you evaluate that is by taking contrast, putting it in a catheter-tipped or TUMI syringe, and you put it in the meatus and put the penis on tension and inject it while taking either fluoroscopy or a series of still plain films. And if there's a urethral disruption, you'll see contrast going everywhere. I have a paper that I wrote when I was a faculty member at the residency program with some of my residents on a guy who came in after being gored by a deer, gored by a deer through his scrotum and into his urethra. The folks in the ED did a retrograde urethrogram and called us, and we took him to the operating room and took care of him. The coolest thing about that whole situation, in my mind, is the fact that he was a civilian trauma patient. The deer was semi-domesticated, and the family provided us with a photo of the rancher and the deer next to each other before the injury. So he's like standing there, and we asked if it was okay to use the photograph in the article when we submitted it for publication, with the understanding that we would protect his identity. And the family said yes, they consented to it. So we put a black box over the rancher's face so that you couldn't identify him. But then we also put a black line over the deer's eyes to protect the deer's identity, and they published it that way. I'll show it to y'all, it's great. So retrograde urethrogram is just for the urethra. A retrograde urogram or a retrograde pilogram, where it talks about here where it says requires cystoscopy, that means you drove a scope up into the bladder, you put a tiny catheter through the scope and actually stuck it into the ureteral orifice on the floor of the bladder and pushed contrast up through it with a syringe and took pictures of the upper urinary tract, okay? A retrograde urethrogram is just the urethra, and it's just done with a catheter tip syringe and contrast. Cystography, to do a cystogram, traditionally this was done by putting a catheter in the bladder. You'd fill the bladder up with contrast. If you ever have anybody ask you the question, how much contrast do you use? The answer is until they feel like they can't hold anymore. Because if they still feel like they can hold more, you don't know if you've reached capacity and you don't know if you have identified any injury to the bladder. This is something that you would do after a traumatic injury where you suspect a bladder rupture, okay? And if they feel like they can hold more, you're not done. Keep filling them. If they're screaming at you that they can't hold anymore, cap the catheter, take the picture, then drain them, take another one, make sure that they didn't have any extravasation of contrast, okay? Voiding cystourethrogram is if you fill the bladder with contrast and then have them urinate the contrast out while you are taking pictures, okay? Not with the catheter still in, the catheter's out while they do the urinating and you take the pictures. But I can speak from personal experience. As a child, I had a voiding cystourethrogram over at Old Dancy, that's now Army South Headquarters, up at the top of Stanley Drive over here. I remember having a catheter put in was not fun. I think we probably still have the picture somewhere. But avoiding cystourethrogram tells you about whether or not contrast refluxes back up the ureters during voiding and whether or not the urethra looks normal on voiding. We also did a voiding cystourethrogram on the guy that got gored by the deer to evaluate his urethra when we were done letting things heal up. So I'll show you a real world example of that. I'll post the paper to Canvas so you can pull it up and look at it. That concludes today's lecture. Any questions? I promise you they will not all run this long. I wanted to make sure we got through this one in its entirety so that we stay on schedule. It is my opinion that we train to standard, not to time, so anytime we get through a lecture early, I will release you. Okay, you're not going to have to just sit around and listen to me talk.